Welcome to Reducing Risk, a series of podcasts from Medical Protection, created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today's topic is, do I have to be a Good Samaritan? What are my risks or obligations? And today I am here with my very impressive colleagues at Medical Protection Society, Dr. Tim Cookson and Dr. Sam King. Hi, guys.
Hi, Lucy.
Hi, Lucy.
So look, we're all doctors and we all work as advisors for MPS. And in fact, I think that between us, we have about 40 years of experience in giving medical legal advice. Is that right, Tim?
I can't count that high. Sorry, Lucy.
I think Lucy and I combined have probably got 3 years between us. So Tim, you've been here an awful long time.
So look, in our last podcast, we were talking about a doctor's obligation when providing care in an emergency situation away from their normal working environment, but while they're still in New Zealand. But today we're going to talk about what we should do if we're overseas and we encounter an emergency. And we're also going to talk a little bit about providing medications for expeditions or for ship's captains, which may seem a bit tangential, but it's something that's come up as a case recently, which we thought might be helpful to share. So let's imagine a scenario. You're on holiday. You're skiing in Japan, in fact. Lucky you. And you're skiing off-piste and you come across an accident where a young man has had a significant head injury and other injuries, and it looks like he fell over a bluff. There's no cell phone reception, and you're worried about his airway, and he's also actively bleeding from a leg laceration. The young man is unconscious, and his partner, who is distraught, is screaming at you to help him. What do you do?
Well, I think we need another podcast from an ED specialist to describe exactly. Oh, no, sorry. This is a medico-legal podcast.
This is a medico-legal
So we're not going to give you advice on trauma management. But from an ethical and medico-legal standpoint, I think the right thing to do is to help. Now, obviously, if you're skiing with someone else, or if you can stop the girlfriend from screaming, then you'd send them off to get, proper first aid care, because there ought, you would hope, to be somewhere near that there'll be some help available. Though I guess if you're off-piste and a long way off-piste, then they would need to be going somewhere until they can get phone reception and then calling or whatever. But it's the classical Good Samaritan situation. And as we heard on the last podcast, MPS indemnity will cover us anywhere in the world for those Good Samaritan acts. Now, you need to try and provide, obviously, the care that you're able to. And in a situation like this, you won't have any equipment with you. So it'll be just providing basic first aid, making sure he's in a recovery position, if he's unconscious, that kind of thing, warm enough, and try and keep your patient alive until the emergency services arrive.
Yeah, I think we'd all agree that in that sort of situation, it's the right thing to do, to step in and help. But would that be the same if we were in, say, America, where they have so much litigation, or in China? Do you think that that's the right thing to do, to step in to help?
Yes, I think, your MPS indemnity would still cover you, but I suppose the risk of actually being sued would be higher in some jurisdictions. But I hope that wouldn't stop us acting in an ethical way and helping. So basically, if we come across an emergency while we're on an overseas holiday, we should provide help. But look, we probably would say that you really want to limit your help to that is necessary to keep the patient alive until the local emergency or medical services arrive, and you can hand over to someone else. And your MPS indemnity will cover you for that. So it's yes, help, do what is necessary, but maybe just do what's necessary rather than heroic, hopefully keeping things in status quo until the local emergency services arrive.
Yeah, and as we talked about last time, it's important that you don't accept payment for any services that you do provide. If the grateful patient who survived wants to shout you a dinner or whatever, I think that would be a reasonable thing to accept. But yeah, having a monetary payment for those services would certainly change it from being a Good Samaritan act to being perceived as being a clinical act that you're doing as a professional, and therefore, your MPS indemnity may not cover it if there were consequences.
Yeah, so a token gift's all right. Is that what we've decided?
I think so. A few $1,000 in a holiday.
That might be a token to you, Sam.
Yeah. Oh, and the Porsche, of course. Yeah.
And how about on planes? Because goodness, I don't know about you guys. Have you both ever been called on to help in a plane?
Yes.
Yeah, because I have.
Yeah, I have too. It's interesting that I was obviously not long graduated and I went to help on a plane, and I think I must have looked extremely young because there was a male nurse who asked me repeatedly, "Are you sure you're a doctor?"
Well, that's interesting because my last experience was when they asked if there was a doctor on board and no one else put up their hand, and I did. They asked to see my certificate before I could provide any assistance. And when I said, well, we don't have such a thing, they said, oh, well, thank you very much, but no, we don't need you. So...
We'd rather let the patient die. Thank you very much.
Apparently.
I think in some jurisdictions, doctors have little licenses, like a driving license, do they? Yeah, we just don't have that, do they? So, when we say, yes, I'm a doctor, I suppose they could get on the Wi-Fi and look you up at the medical council register. But other than that, we don't really carry proof of professionalism, do we?
No, we don't. Although usually on most planes, there are multiple people who would be doctors or nurses or, some form of clinician, isn't there?
You'd think so.
So going back to that plane scenario, is it the same on a plane? Do we offer help on a plane? Have we got an obligation to offer help in the same way?
Yeah, I think so. I think that our medical council would certainly have that expectation. I'm sure that overseas, though, in different jurisdictions, that might differ. On a plane, there is normally a system where the pilot can call an international medical team, I think, and they will give advice on management. But obviously they need someone on board to be able to carry out any instructions. So I think that ethically we do have a responsibility to help, and we should. And as long as you're not impaired, as we talked about in our first podcast, and in those sort of situations, your MPS indemnity cover will be fine, will cover you. Interestingly, in the US, the Aviation Medical Assistance Act protects responding providers against liability, except in cases of gross negligence. And I think in the US, they're incredibly litigious, aren't they? So without that, I expect a lot of doctors wouldn't even volunteer that they're a medic and wouldn't want to step in for fear of being sued. The USA and Canada and the UK don't require providers to render assistance, interestingly. But the GMC, or the General Medical Council in the UK, states that doctors have an ethical duty to respond. I think other countries, notably Australia and some in the European Union, require healthcare professionals to respond on onboard medical emergencies. So generally speaking, I think we all have that obligation, don't we, to step in.
It's an ethical one, if not a legal one, isn't it? Yeah. I have to say, most of us dread it, though. It's not what you look forward to, is it? If you're on a plane, and you do worry because often you do completely feel outside your scope. It's a difficult situation, but I think that whole thing about only doing what is necessary to keep the patient alive and thinking about do no harm is really relevant in those situations, that you just do what you can first aid wise.
Well, that's all you can really do. I mean, even for someone with specialist training in, say, ICU, I think they do have a significant kit on board planes, and so that any medics can help, in a practical sense. But even so, there's only a limited amount of things you'll be able to do on an airplane.
I think there was a news article a few years ago about somebody putting a chest drain in on a plane, wasn't there? There was an ICU consultant who happened to be there.
Very handy.
And the patient had a tension pneumothorax, which was kind of handy. But I think that would be the exception rather than the rule. So what about if I'm going on a small Antarctic cruise and the organisers know I'm a doctor and I'm going on the cruise, as a passenger, but they ask if I'll provide medical cover for a small number of passengers and crew should an emergency arise? What about that?
Well, that's getting kind of on the borderline, really, because, if all you've done is agree to provide care in an emergency, then you could potentially argue that, well, there's no contract there, but they're just aware that I'm a doctor, and if there was an emergency that arose, then I would provide care. And so, look, maybe under that you could argue that would be a Good Samaritan Act, but if there was a more formal kind of contract to provide care for non-emergency type medical problems as well, because the Good Samaritan stuff really only applies to a genuine bona fide emergency, and I think that's the key difference. So you're on the cruise and someone has a minor sprained ankle and you see it. No, that's not going to be a Good Samaritan Act. So I think there's some grey areas there, and genuine emergency, yes, it could come under it, but more routine care, no, it wouldn't apply.
And even if it's voluntary and unpaid, obviously that doesn't matter. It's still not an emergency.
Yep. I think that's the key. It's got to be a true emergency.
All right. So if I'm thinking I'm going to do that, what do I do? Do I need to get some additional cover?
I would probably look at the expedition or the company that owned the boat to provide that indemnity for you.
Right.
That would be the most sensible thing to do, particularly if you're talking about travelling in international waters, because a lot depends on which jurisdiction the complaint arises in.
And if you've got Americans on board or, who would want to say, oh, well, we were on an American registered vessel and therefore it was an American state, and try and sue accordingly.
And generally your MPS indemnity is not going to cover you if you're sued in another jurisdiction apart from if it's a Good Samaritan.
That's right.
Yeah.
But not only that, if you're talking about if you're practicing medicine supposedly on American soil, if you like, you'd need to inquire as to whether you had to be registered in that jurisdiction to even practice medicine. So, yeah.
And then which state is it?
Exactly. Exactly.
Or is the ship registered in Panama, which may not have such strict rules?
Yeah. And are you expected to go and find out is the problem, isn't it? It's probably just to say, actually, I'm on holiday. I'd rather not be a doctor, please. Yeah. Yeah,
but knowing that if there was a genuine emergency, you would step in and help.
Then it would kick in. Yep. But you're not going to treat everyone's cough and cold during the trip. Yep.
And is it the same if you're accompanying your son's hockey team to a tournament in Canada and they ask you to come along as parent support, but they say, look, it'd be great while you're there if you could provide some basic medical care on the sideline as the team doctor?
Yeah, it's interesting. I mean, I guess, are you asking whether MPS would cover that?
Yeah.
My expectation would be that if you've got New Zealand residents who are travelling and you treat them and then they didn't like the treatment that you provided them, the most likely scenario is they would lay a complaint back in New Zealand, in which case I believe that MPS would cover that. If in the unusual circumstance that they decided to make a complaint while you're sitting in Canada, I don't think that MPS would cover that.
So if a complaint went to the Canadian authorities rather than New Zealand authorities. Yep.
But for MPS to cover, it'd have to be your scope of practice. So actually, if you were providing services as a team doctor to the hockey team, you'd have to be within your scope as well for MPS to cover you, wouldn't you?
So again, the ophthalmologist treating sprained knees
is a no. Yeah. And I kind of think in those situations it is good to ring and actually check. Because obviously, often these things are very nuanced. But I think offering to provide medical care overseas, there's not only the indemnity issue, as you said, there's also that issue of registration. And would you be considered to be offering care in Canada, and have you checked with the Canadian Registration Authority as to whether you're allowed to do that or not? Because we've had that issue quite a lot with telehealth, haven't we? If you're sitting in America and providing telehealth care to people in New Zealand, do you need to be registered in America? And it's different for different places, so it's really quite complicated. So I think if you're in that situation, maybe if you're thinking about it, ring up.
Yeah, I think getting in touch with membership and just advising them what you're about to do and just check on confirming the extent of cover that would be available would be a good precaution. So The other aspect that often happens is that, the teen's about to go off to Canada, and you as a GP, for example, get asked to provide some medication that on a just-in-case basis. They've cut themselves, the wound's starting to look a bit mucky, and so they're anticipating it might need antibiotics, and rather than having to go through the Canadian medical system, can we have some antibiotics, please, to take with us to use in that kind of situation? What's the scenario there, Lucy?
Yeah, it's probably a little bit grey, really. But I think if it's for a named patient that you have personally assessed and decided that medication would be appropriate for them, I think it should probably be a private script rather than a funded one. But I don't know, Sam, what do you... I'm a little bit grey on this, but I think it'd be fine to write a script for a patient to take some medication with them if you've assessed them and decided it's an appropriate medication for them. I can't see that, you've done that prescription within New Zealand for a patient you've assessed. I think that would be all right.
I think all of us as GPs have done exactly that, haven't we?
Yeah.
Over
I'm
the
not
years.
admitting to anything on air, I'm sorry. I might have done it once or twice a week, but no, I think, I agree. I think that we've all done it, and it seems very sensible because it is for a known patient.
That you've assessed,
Yeah. Then there's the different scenario about which you talked about in the introduction. So what about when the captain of an offshore vessel comes in and asks for a script for a multitude of emergency drugs that they need to have on board in order to comply with international maritime laws? Where are we at with that one, Lucy?
Yeah, that's actually very interesting because I think offshore vessels actually have to have certain medications on board for them to set off, and they have to carry them, don't they?
Yep, they certainly do, and I understand it varies. What is required depends on the number of crew, the size of the ship, and also the distance offshore that they go. And the maritime rules state that the owner and master of a ship that is required by Part 50 to carry medicines must ensure that each medicine is replaced, A, as soon as possible after the use of the medicine, or B, as soon as possible after it expires. And the requirements for each medication is very specific. For example, if you're a vessel of 30 metres or more operating in coastal limits, you need to carry 40 paraffin gauze 10 by 10 centimetre dressings. How they decide that 40 is the right number, goodness knows, but there it is. It's in the Act.
It's quite interesting reading the maritime rules. They've got these long lists of everything that they have to carry and the number they have to carry depending on what class of vessel they are. And they can't sail without what's been specified in that list being on board. So how do they get them? Because obviously a ship's captain, can't necessarily just walk into a pharmacy and say, can I have these medications?
Well, we've had cause to ask our lawyers about this because we had a few inquiries recently. One of the doctors had called us because they had been criticised for providing scripts for medication to a sea captain to replenish his stocks. So clearly prescribing for a ship's medical kit falls outside the normal medical council prescribing guidelines, which require you to have assessed the patient and determined the prescribing is safe. And if anyone hasn't already done so, good prescribing is a must read really for all of us because that's how we're measured in terms of medical council processes. However, Section 44 of the Medicines Regulation Act allows for certain situations where prescriptions for prescription medicines are not required. One of those situations is where a prescription is for a master of a New Zealand ship and the medicine is prescribed by rules under Section 36(1)(e) of the Maritime Transport Act. On this basis, if a patient comes to you and is the master or operator of a New Zealand commercial ship requesting access to medications required under Part 50 of the Maritime Rules, then these medications can be dispensed to them without the required prescription. You would, however, need to review the rules in Part 50 of the Maritime Rules to check what medications you can provide this way. So it's fairly straightforward, but a little tricky. So you really ought to read it up before you prescribe anything or provide any medication.
Yes. I mean, it's interesting because I have to say I've learned a lot about this by preparing for this podcast, because as a GP, I don't think I had ever heard of Part 50 of the Maritime Rules. And, I think if a ship's master had come to me asking me, I wouldn't have had a clue. So I've learnt a lot. What I've also learnt, though, is that this system only works for commercial vessels. And if a non-commercial vessel needs medications for a medical kit, they actually need to approach the local medical officer of health, who is allowed to do this under medicines regulations. However, the complication of all this, so we've said that commercial owners or operators can get it under Section 36 of the Maritime Transport Act, that non-commercial vessels can get it from the local medical officer of health. But for access to controlled drugs, and for non-commercial vessels to get controlled drugs, in addition to the requirement to have an approval from the medical officer of health, the person to whom the drugs are being provided must belong to a class approved by the Director General. Doesn't this get complicated?
My head is spinning just a wee bit.
I wonder if we've lost all our listeners here and they're thinking, what are they talking about?
I hadn't got past 36(1)(e) of the Maritime Transport Act, let alone on to here. Because the problem is that there's actually not currently a Director General approval in place for this class of vessels. Look, we understand that MedSafe is currently progressing an approval, but there seems to be a big gap. Non-commercial captains don't seem to have an avenue to legally obtain controlled drugs for their medical kits. And of course, I don't know the details of what's needed, but I think for a Class 1 offshore certificate, if you're a yacht, for example, you need to have a life raft, you need to have a medical kit, and that's specified exactly what needs to be in that medical kit. And Class 1 drugs are included in that list. So on the one hand, to get your Class 1 offshore classification, you need it, but how do you get it?
Interesting. I think there is a company, the Oceania Medical Company, that provides the fully stocked medical kits for boats, and these comply with international maritime requirements. So it makes it easier. They've got a specific license which allows them to provide the required medications. So you could always refer your requests to them. But I understand that the kits are in fact very expensive, as you would imagine.
Yep. So there is in fact a route to get them, and the people who are contacting our doctors are just trying to get in through the back door. Is that what you're saying, Sam? And avoid those costs?
Would be cheaper, wouldn't it?
Yeah.
We actually had a similar case a few years ago with an Antarctic expedition that needed opiates for their medical kit in Antarctica. And they were from an overseas jurisdiction. They were just passing through New Zealand. Were told they couldn't bring opiates through New Zealand because it would be considered importing them. And so were told to get them when they were here. Turned up to a GP in New Zealand saying, please, can we have some opiates for our medical kit? And of course, that became exactly the same problem. It's not for a named patient. The patient hasn't been assessed. You can't do it. So there are these funny situations, particularly with controlled drugs, where you've really got to stop and think, is this within medical council medicines control situation? Can we prescribe? And I think in those specific situations, if you've even thought that, seek advice probably before you write that script, because you can imagine, particularly for controlled drugs, it could be looked on very poorly if you have used a patient name that isn't the patient who's going to get it, or some other situation where the patient hasn't been assessed.
Yes, you can certainly imagine the medical council not being convinced that was conduct appropriate for a medical professional in New Zealand. Even though it's perfectly understandable and seems perfectly logical, but it just falls outside.
And you're trying to help.
Yes. Yeah.
As we often are. So, what have we learnt today? I don't know, Sam, what have we learnt today?
We've learnt that it's good to be a good Samaritan, or it's the right thing to do to be a good Samaritan, but perhaps think about it before you do it in terms of your indemnity, and think about your scope of practice and what the best thing to do is in each situation. I think that if you've been asked to be an unofficial medic, that you do need to think about that and whether or not you've got indemnity cover for it. and definitely ensure that you're working within your scope.
And it seems pretty clear that if you're on a plane, anywhere in the world, going anywhere in the world, yes, look, you're covered for Good Samaritan Acts on the plane. But if you're driving around the US and you come across a car crash, it's not quite so clear that you're protected there. The Good Samaritan Act or provision of the medical protection would give you some protection, but you could still be sued.
Yeah, your indemnity will cover you, but still, but I think in general, ethically, it is the right thing to do to help, even if it's just to keep the person alive till somebody else gets there. That you do the minimal needed to actually
the right thing to do.
Try and do the right thing. I think that's what the gist of this is. But look, if you've got a particular situation, if our listeners have got a particular situation that they want to discuss with us, they can always call us on the advice line. We may not know the answer, but we can always try and find out. So thank you, Sam and Tim, for helping with that discussion. And thank you to our listeners for listening to this podcast. I hope it's been helpful. And we look forward to catching up with you in our next podcast. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email us on ednzpodcasts@medicalprotection.org.